Welcome back. Our next electrolyte that we're going to talk about is potassium, which is our major intracellular. Just as sodium is major extracellular, potassium is our major intracellular ion. And if you think about it, really, when we do lab values, we measure what's extracellular. We measure what's in our intravascular. We measure serum. And so a normal sodium level is 135 to 145, which is a much bigger number than normal potassium, which is 3.5 to 5.0. And that's because most of the potassium is inside our cells. It's not out in our serum. And we don't measure intracellular values. So anyway, I just think that's an interesting point. So most of it's inside our cells, so little of it is outside our cells at any one time until we get abnormalities. Potassium is necessary for neuromuscular control and precise regulation of skeletal, cardiac, and smooth muscle activity. And the cardiac, as we talk about imbalances in potassium, its effect on the heart can be profound, and in fact, too high or too low of potassium could kill a patient. We know that potassium levels influence acid base, and we'll review that a little bit. It participates in many enzyme reactions, such as glucose into glycogen, carbs into energy, and amino acids into proteins. And just like sodium, most of our potassium, the vast majority, is in our diet, what we eat. Unlike sodium, which has other routes of excretion, the vast majority of our potassium is lost in our urine. So anybody who is not urinating properly, who has renal insufficiency or whatever, is going to start retaining potassium. So hyperkalemia would be a potassium level greater than 5.0. And this is, I've started because this is probably the singular most common reason that someone becomes hyperkalemic is because they're not excreting it in their urine because of decreased renal excretion. Certainly another thing could be excessive potassium intake, but this isn't your norm. I mean, how many of us eat a bushel of bananas a day? Not too many. But do remember that if somebody is on a salt-restricted diet and they're using that fake salt substitute is actually potassium phosphate. It's got K in it. So you might wind up becoming hyperkalemic because of that. Cellular breakdown, since potassium is a major intracellular ion, then if crushing injuries, trauma, etc., this can lead to hyperkalemia. Adrenal insufficiency, if we're not cranking out aldosterone, then we're not retaining sodium in the water, and we're also not excreting and secreting and excreting potassium. So you could wind up with hyperkalemia because of that. Acidosis goes along with hyperkalemia, and we'll see in a minute why. Burns could go either way, high or low K. And then, of course, diuretics, if we're giving somebody a potassium-sparing diuretic, instead of looking for hypokalemia, we'd actually be looking for potential hyperkalemia. ACE inhibitors and NSAIDs might also be a source behind hyperkalemia. In our assessment, what we would look for is weakness and flaccidity and some GI symptoms such as nausea, diarrhea. Hyperkalemia increases peristalsis. So rapid belly sounds, intestinal colic, diarrhea might be something that you might find in a patient who's hyperkalemic. But the big deal here is the effect of potassium on the heart. And as potassium levels rise, it will see EKG changes such as a peaked T, but more so, we get a prolonged PR interval and a widening of the QRS. And if you recall back to EKG analysis, the QRS is supposed to be very, very rapid, about less than 0.11 seconds. And so you actually get a visual representation. I'll just do this up. I'll use both hands. Visual representation of the heart contracting very, very rapidly. The effects of hyperkalemia are to decrease contractility and widen the QRS. So that when you see a widened QRS, it literally is telling you that the heart is now going boom, boom, boom. Very poor contractility all the way to flat line when you're dead. So it could lead to VTAC, cardiac arrest. The treatment for hyperkalemia, if it's rising slowly, is to give K-Xylate. I love drugs that actually tell you what they're doing. The K, potassium, Xylate, exited out of the body. The K-Xylate. But K-Xylate, you remember, is a cation exchange resin. So it's getting rid of potassium, but you're giving them another cation. And that other cation that you're giving them is sodium. So you're giving them a sodium load in relation for getting the K out of them. So you might have to deal with that as well. But K-Xylate is not something that you wouldn't give somebody a K-Xylate enema if their K was 8 and life-threatening potassium. Fooey with that, they'd be dead before you got the enema. So you would want to give something intravenously and blast them quick. So IV diuretics, specifically loop diuretics, which will give you the best potassium loss. So usually it's Lasix. Another thing that can be given is a little cocktail of insulin and glucose. It's actually the insulin that's effective. Insulin will drive potassium into the cell, back into the cell, so that it'll drop your serum K. And because it'll drop your blood sugar as well, you cover them and you prevent a hypoglycemic episode by giving this little cocktail of insulin and glucose. This is transient. You could dialyze them on an emergent basis. They could slip a Vaz cap in and immediately hemodialyze them within half hour and an hour of getting there. And because hyperkalemia is associated with a metabolic acidosis or an increase in H ion secretion, giving them sodium bicarbonate would be another method to decrease the acidosis and get the potassium level down. So hyper-K, some of the things that we can give to treat them intravenously. Remember that hyper-K decreases contractility of the heart, and calcium increases contractility. So we might give them calcium gluconate, very rapid onset, and lasts for about 30 minutes. We could give them this insulin glucose cocktail. Onset is a little slower, but it lasts for several hours. And again, bicarb, about the same as insulin glucose. Onset is around 30 minutes and has several hours lasts. So that's hyperkalemia. Here's hypokalemia. How can we become hypokalemic? And this would be a K less than 3.5 MEQs per liter. And the causes are either you're not taking in adequate dietary potassium, or you're on an IV and you don't have enough potassium in the IV, or you've got no potassium in the IV. So as nurses, we need to monitor the patient's daily lab work and talk to the doctor about, hey, do we need 20, 30, 40 K in this IV? The loss of GI secretions, we can lose electrolytes in our gastrointestinal secretions. So somebody with that, such as nasogastric suction or emesis, or use of laxatives, or rapid transit through the bowel, ulcerative colitis, we could lose more potassium than normal. But this is probably the biggest cause of potential hypoglycemia, and that's the use of diuretics and not following them with potassium supplementation appropriately, or just not monitoring them. Interestingly, Low sodium diets actually causes a release of aldosterone because the body says, wow, I'm not getting enough sodium here. I'm going to crank out aldosterone and retain some sodium, keep it back. And when aldosterone is secreted, recall it retains sodium and water, but you get rid of something in exchange, that's potassium. So if you stimulate the release of aldosterone, you actually will lose more K than normal. And glucocorticoids are the same deal. You're causing sodium retention and potassium excretion. So in our assessment, we would look for malaise, hypoactive reflexes, and just as we could have in hyperkalemia, we had intestinal colic and diarrhea. Now, in hypokalemia, you have diminished intestinal motility, abdominal distension, nausea, vomiting, anorexia, and decreased activity all the way, really, to potential paralytic ileus, quiet bowel sounds. And so again, if you think of your med-surg client and they're NPO or they're not eating much and they're just getting IV stuff, if they wind up getting hypokalemic because you're not giving them parenteral replacement and it's slowing down their gut and you keep listening to the belly sounds and saying, ooh, they're not there, I can't feed them. So you keep them on IVs day in, day out. You know, this major thought is like check their K. Are they hypokalemic? And that's why I don't have good bowel activity. Correct the hypokalemia, and then you can start feeding. Again, EKG changes. But now, as in hyperkalemia, where it's slowed contractility and impaired conduction across the AV valve, AV node, pardon me. Here now you get an irritable heart, and so premature ventricular contractions, an irritable ventricle, all the way to VTAC, VFib, potential cardiac arrest. This is very rare, but there is a thing in the literature as familial hypokalemic respiratory paralysis. It's extremely rare. But hypokalemia also depresses insulin release from the pancreas, and so can lead to glucose intolerance. But the biggie deal here is its profound effect on the heart. So in our treatment of hypokalemia would be to give them potassium supplements, foods high in K, IV, or PO supplements, whatever. Now, if you're giving intravenous potassium, there's a golden rule for potassium replacement. And that is, if you're on a regular nursing floor, you're not in an intensive care unit, the golden rule is no more than 10 MEQs of KCl dissolved in no less than 100 mils of saline and infused no more rapidly than over 1 hour. It's extremely caustic and irritating to veins, so when you try to give it through a peripheral vein, patients often will say, ooh, it burns, it stings, and you have to slow down the rate. So use a central line if you do have one available, because again, as I say, it's very irritating to veins, can lead to tenderness, erythema at the site. But also never, never, ever, ever give IV push or give it too rapidly, because it will stop the heart and will cause a cardiac arrest. Now, I say that this is the golden rule. No more than 10 MEQs per 100 over an hour out on the floor. So if you were ordered to give 40 MEQs, you would get 4 little baggies of 10 MEQs each. So over 4 hours, you would infuse your 400 mils, and each containing 10 MEQs per 100 mils. Now, in an ICU, we do things differently. We give more than 10. Maybe we'll give 20 an hour. But that's because we're monitoring the patient. They're on a monitor. We're looking at their cardiac function. We have them moment to moment that we're watching. So we do things a little differently in an ICU than you could ever do on the floor, because we just can't monitor them that closely. And of course, here's our little picture for potassium. Our little doggies in their little Chiquita banana outfits. And interestingly, whenever I ask anybody what food would you say, give your patient if you wanted to increase their serum potassium, everybody universally says bananas. All right, but please note that an avocado has more potassium than a banana. A baked potato has more potassium than a banana. So give them a list of foods high in potassium. My poor mother was on chronic diuretic therapy, and her doctor told her, eat a banana every day. So even though I could say, Mom, you don't have to have bananas all the time. No, the doctor told me I must have my banana. She never wavered because she was of that era where the doctor was God and you never questioned. Even though your daughter's a nurse, don't believe her either. So, but anyhow, give your patients more of a choice. Aren't they cute? I know my little dog things are crazy. Regulation of potassium. Potassium, as we know the relationship of aldosterone, that when aldosterone is secreted, we retain sodium and water, but in exchange, we secrete and excrete potassium. And then there's the hydrogen and potassium ion exchange. So let's look at that. For every 0.1 decrease in pH, getting more acidotic, you get a 0.05 increase in serum potassium and vice versa. So K and pH, elevate the K goes with acidosis, lower the K goes with alkalosis. Also, in an acidotic state, the excess hydrogen ion actually will go into the cell, it will move intracellular and hide there to buffer the serum acid load. But when it moves in, it kicks the K out in its place in order to maintain cellular neutrality. So again, acidosis, the H moves in the cell, kicking the K out. So acidosis and hyperkalemia, alkalosis and hypokalemia. Again, the same thing saying. In acidosis, the H ion goes into the cell to buffer, so it kicks out the K, and this is just repeating what I've said. So let's take our last electrolyte, calcium. So calcium, remember that calcium and phosphorus have an inverse relationship in the body. And if the calcium goes up, the phosphorus goes down, and vice versa. So homeostasis is maintained by the parathyroid glands. So if we need to elevate, if the calcium level's down, the parathyroid glands will release parathyroid hormone. And this causes a release of calcium from the bone, because 99% of our calcium is stored in our skeleton, it's in our bones. Calcitonin from our thyroid returns it to the bone. So parathyroids will increase serum calcium, calcitonin from our thyroid returns it to the bone. Vitamin D is is implicated in homeostasis of calcium. There's renal conservation or losses, and there's uptake by the GI tract and the bone, all of these things that help to, in the maintenance of a normal serum calcium. Remember that you need activated vitamin D to absorb calcium. And that's one of the functions of the kidney, is to activate vitamin D, which is another reason why patients with renal disorders are low on calcium. Okay, so most calcium exchange is from sites in our bone, and it can occur within minutes to an hour. It's very, very rapid. Well, as I said, 99% of our calcium is stored in our bony matrix. Only 1% is out of it, and half of that's bound to plasma proteins. Some of it's combined, for example, with phosphates. So of the itty-bitty bit the 50% of 1%, that's sorry, half a percent, is physiologically important. And that is important, as we know, calcium is important in maintaining cell membrane permeability, enzyme reactions. It's important in blood clotting. It facilitates nerve impulse transmission. This is a big one. And, of course, it's necessary for adequate contractility and automaticity of the heart as well. And here's our little, we need little growing bones, and we need a little help to build strong bones. So little dogs are helping the kid. Okay, so calcium, interestingly, remember some of it's bound to protein. And calcium, your calcium level varies in the same direction as your serum protein. So if you are low on protein, your total calcium level is also going to be low. Also, in an alkaline pH, more calcium is even bound to the protein, and vice versa. In an acid pH, less calcium is bound. So if you have a pH problem and you're looking at your calcium levels, the treatment isn't to change the calcium. Your treatment really is get the serum pH back to normal, and then your calcium level will also get back to normal. Magnesium. A low magnesium level impairs release of parathyroid hormone, and it also inhibits the bone's response to normal parathyroid hormones. So low mag could cause low calcium as well. So let's look at high mag, or high calcium, pardon me. So hypercalcemia is greater than 10.8 milligrams per cent. Some of the reasons to be hypercalcemic include malignant tumors, and this would be especially a bone tumor such as Ewing sarcoma. Prolonged immobilization. Remember that 99% of our calcium is stored in our skeleton. It's in our bones. And we need, in order to maintain a good skeleton, or scaffolding for our body, if you will, we need to do weight bearing. We need to have a reason to have that skeleton. And so people who have prolonged immobilization and aren't doing weight bearing, over time, the skeleton says to itself, you don't need me, I guess. And so, I'm making this sound silly, but what happens is that the calcium begins to leave the bone, and you get bone demineralization. And that increased serum calcium then can lead to precipitate salts, and you could wind up with kidney stones. So prolonged immobilization can lead to hypercalcemia and kidney stones. Hyperparathyroidism, since it's parathyroid hormone that pulls calcium out of the bone, well, if it's overactivated, and inappropriately so, then hyperparathyroidism would lead to hypercalcemia. So the symptoms of hypercalcemia include a decreased nerve and muscle tone. And actually, I have to go to hypocalcemia in my brain because I just think of low calcium seizure activity before I go to high calcium decreased nerve and muscle tone. So decreased nerve and muscle tone, GI slowdown, so nausea, vomiting, anorexia, constipation. Here's an interesting thing, excessive thirst and behavior changes. Now, especially behavior changes, these are kind of unique to an electrolyte imbalance that we usually don't see. And then slower heart rate. We might see a slower heart rate because digitalis, which is a negative chronotrope, it's positive inotrope, makes the heart work better or contract better, but it's also a negative chronotrope, it slows our heart. Well, one of the actions of DIG is to prevent calcium extrusion from the cardiac cell. So it keeps calcium in there longer. So if you had a high calcium level, it could potentiate the digitalis and lead to potential digitoxicity. So a bradycardia, first-degree heart block, something you might be looking for in hypercalcemia. Low calcium, which we probably see more often than high calcium, would be a calcium level less than 8.5. And major causes include renal failure, because remember that phosphorus and calcium live in the body in an inverse relation. And we excrete phosphorus in our urine. It's one of our buffers, phosphoric acid. So if we're not excreting phosphates, the phosphates build up, therefore our calcium goes down. Also remember that in renal failure, we're not activating vitamin D, which is necessary for calcium reabsorption. So we've got a couple of reasons in renal failure why low calcium is problematic. We know that this happens, so we monitor, we give drugs, and we prevent this from happening. But if we did not do this, then bone demineralization and literally renal rickets would be the result of it. Vitamin D deficiency, because we need that for calcium reabsorption. Massive blood transfusions. The citrate preservative that is in the bag of blood, it is to prevent blood from clotting. But if you're giving massive, not just a couple units here, we're talking about giving your patient 10, 11, 12 units of blood, active bleeder, giving them massive blood transfusions. The citrate preservative in the banked blood will begin to bind and precipitate out the patient's own calcium. So massive blood transfusions could lead to hypocalcemia. And then again, remember that low magnesium levels. And mag levels go along with K levels. So if you've got a low K, you've probably got a low mag as well. And so this reduces parathyroid secretion or increases its resistance. So that could all be in line with leading to low calcium. So the symptoms of low calcium are neuromuscular irritability, if you will, and numbness and tingling and even potential seizure. Positive Schwaztek or Trousseau sign, and if you'll recall, the Schwaztek signs, we tap on the trigeminal nerve here, and it literally leads to a little local spasm. The Trousseau sign is when you put a blood pressure cuff on somebody's arm, and you pump it up, and you leave it, you take it down really slow, and the patient's going, get rid of this thing. Remember when you were first learning how to do vital signs on each other, and your lab partner was like bringing it down so slow, and you thought your arm was going to die? Well, a Trousseau sign is where you literally get what is called carpopedal spasm, and your hand comes into this like claw. And then when you let loose of the cuff, your hand doesn't just immediately go, oh, thank you. It may take a couple minutes before this muscle spasm begins to relax and the hand can relax. That takes time. Blood pressure cuff, all that sort of stuff. So I like this one. Quick, down and dirty, positive Schwaztek. Other symptoms of low calcium are nausea, vomiting, diarrhea, and if your calcium got really too low, since calcium is necessary for clot formation, you could have some coagulopathy. And we are done. So thank you very much, and I want you to remember to look at your case studies, do your forums, talking with your colleagues, and thank you for your attention.